Thank you very much for inviting me to be a part of this conference. I think it is an awesome opportunity to be able to bridge this gap between exercise physiology and rehab science. A lot of the work that I've been engaged with in the last couple of years and what I'm going to present to you today, I think is really that area where this intersects pretty well in the neuro world, which is exercise and neurologic disability. So I'm going to talk about cardiorespiratory fitness and physical activity after stroke, complexity, and some of the potential solutions for that. At the time that I got invited to do this talk, I was the director for the physical therapy division at the Medical University of South Carolina and program director for the physical therapy program. But since that time, I've changed positions. So I've got a new cover slide for you, reflecting the fact that I'm now at Brooks Rehab here in Florida. I'm stationed out of Jacksonville. I'm the Vice President of Clinical Integration and Research. And it's really exciting for me to be back in Florida. I spent a good bit of time here back in the early 2000s, but also to be able to do the kind of work that I've always wanted to, which is integrating and implementing the type of work that I'm going to be presenting to you today. So I'm very excited to be here. So there's disclosures. I had several grants that were active while I was preparing this. One was my VA award, also the P20 at MUSC, which is the South Carolina Research Center for Recovery from Stroke, as well as a small grant that I got from the Health South Corporation back in 2015. I'm going to present some of those data. I also wanted to point out my collaborators. Pam Duncan has been somebody whom I have considered a mentor, friend, and colleague for almost 30 years now. I was the research coordinator on Pam's first grant that she got through the VA back in 1991, before I even went to PT school. She is actually one of the multiple PIs on the proposal we have going in, along with Amy Pasfa at Duke, who's done a tremendous amount of work in this area, especially in those with heart failure. I'm going to present some of those data. And also Janice Ng from the University of British Columbia. Janice has done a tremendous amount of work in terms of moving the field for neuro rehab forward in the Canadian area, and we're super excited to be collaborating with her at this point. So there's two things I want to start off with, two truths that I hope that we can all agree are inarguable. All right, the first truth is exercise is good for you. And I hope that in this group, there's really no debate in that. But it's also good for you even if you've had a significant neurologic injury like stroke. And it's not just that it's good for you because we all should be exercising, makes us healthier, but it helps with cognition. It helps reduce depression. It helps increase attention. It helps as a primer for other types of interventions. It is theorized to increase brain-derived neurotrophic factor to be able to increase plasticity for the whole system. So yes, we need to agree that exercise is good for us. My favorite quote about this, my colleague and friend Chris Gregory at MUSC has this quotation on his dry erase board. I've always attributed to him, but it's actually a quote from Frank Booth, that there is no singular approach more effective than regular exercise for reducing the risk of virtually all chronic diseases simultaneously. And I just love that approach and how we're moving our field into this direction. The second truth that I want everybody to be comfortable with is that stroke is a vascular condition. And yes, it is a neurologic condition, and there are lots of neurologic consequences to having the stroke. But it is also a vascular phenomenon that either we've had a clogged artery or a burst artery in the brain, and we need to be able to treat the vascular component to stroke as well as the neurologic condition. Pam is often referred to stroke having neurologic sequelae, and that we have historically undertreated and underdosed the vascular component for this. So if we recognize that individuals post-stroke on average are not as fit as their age-matched counterparts, that they have not exercised a whole lot up until that point, or at least at the time of the stroke. This is a really, really important thing to be able to fight the decondition that is part of the process acutely, but also to prevent further deconditioning and consequences that happen long time after the stroke. So it's a huge impact on cardiorespiratory fitness. So the lifetime risk of stroke in the United States is about 18 to 20% of us are going to have a stroke. It's the fourth leading cause of death in the United States. Peak VO2 levels are near minimum after stroke, which severely affects individuals' ability to engage in physical activity and other exercise. There are severe alterations in muscle fiber characteristics. There's increased pro-inflammatory markers, altered glucose, insulin metabolism, and impaired autonomic control. And there's significantly impaired respiratory dysfunction. So all of these conditions lead to a system that is more liable to secondary consequences, such as another stroke, heart attack, vascular death. And those are the things that we are focusing on in our research to really think about how to be able to prevent these secondary complications after stroke. So the guidelines tell us and tell all patients with stroke that once you discharge from rehabilitation, you need to exercise 3 to 5 days per week, 20 to 60 minutes per session at a moderate to intense level of activity. However, most of our patients with stroke cannot do this. So we are literally giving a home program to a group of individuals that cannot go home and do these things that we're talking about. So these were the guidelines from the American Heart Association and American Stroke Association in 2014 for physical activity. In 21, we had new guidelines for the prevention of stroke in those with that have had a stroke already or transient ischemic attack. And for those who are capable of physical activity, we need to engage in at least moderate intensity aerobic activity for at least 10 minutes 4 times a week, or vigorous intensity for a minimum of 20 minutes twice a week. So again, we're in this situation where we are recommending people to do a certain amount of exercise to prevent further complications, recognizing that they are not physically capable of doing the exercise that we're talking about. So to illustrate this, these are the data from Pam Duncan's LEAPS trial that was published back in 2011. These were those folks that came out of usual care. And standard practice indicates that those folks have slow walking speed. They're less than 0.8 meters per second on average. They're less than that speed predicted to be a community ambulator. They have poor endurance in 6 minutes, which is a tremendous marker for physical activity in the community. They take fewer than 1,800 steps a day when the average American takes over 5,000. They have impaired balance, which makes them a falls risk. Their mobility further declines in the first years after stroke, and 25% of individuals do not engage in any physical leisure activity at all. So if we have the goal of preventing further secondary stroke, heart attack, vascular death, we have to address the issue that we're sending people home from rehabilitation with recommendations that they're not able to do. So we could all point fingers at why this is. And part of the fingers need to be pointed straight back at the rehabilitation community. All right. Individuals, while they're in rehab, only spend about 10 hours per day out of bed, and 87% of that time is sedentary. And those of us in physical therapy, occupational therapy can say, well, that's because they spend so much time on the nursing units and they're not active there. But 61.6% of the time that they spend in therapy is sedentary. And that's the part that is particularly intolerable to me, that when we have shortened length of stay, that we only get each patient for about an hour to an hour and a half a day of their 3 hours total of therapy and inpatient rehab. We have to make the most of that time to be able to increase functional capacity. Intensity is super low in inpatient rehab. Heart rates reach aerobic training zones for only 2.8 minutes, which is less than 5% of the session. And the median number of steps taken during inpatient rehab is 63 steps per session. And the amazing part of this is it doesn't get more as somebody progresses through rehab. And it took me a long time to kind of wrap my head around how is it possible that people don't get better in terms of the number of steps they take when they're improving in all of these other measures. And my guess is that the average length of a gym is about 63 steps, because therapists will come in, they'll park their patient at one side of the gym, they'll put a chair at the other side, and they'll walk over there and they'll sit down in the chair and they'll talk for some indeterminate amount of time and stand up to walk back, not because the patient says they're not tired anymore, not because their heart rate or blood pressure have come down into an area where you want to engage in activity again, not because they've asked them to rate their perceived exertion and it's down into the area where you're going to resume activity. It's just that you're done with the story that you're telling and you get up and you walk back to the chair. And I've seen it. Sadly, I can say I've done it. And it's a part of rehab that really needs to be able to change. It has to be that we incorporate dosing of cardiac type training in rehab. There was a study done not too long ago where 88% of physical therapists in the United States recognize that aerobic training needs to be part of their rehabilitation of patients with stroke. That's pretty good. It makes me somewhat sad that 12% don't know that, but I'm pretty happy that 88% do. The terrible part of the story is that 84% of therapists in the United States can give you at least one reason why they don't do this. And so this is something that we simply have to be able to change. If we don't change it, we're not ever going to address the issue at hand. And that issue is that we're wildly underdosing. And because of that, physical activity is not being promoted in the home and community because they don't get enough practice at it during rehab. All right. If you take 63 steps per day through a 12-day inpatient rehabilitation stay, and somebody gets 3 days per week for 4 weeks of outpatient therapy, where they're taking 357 steps per day, by the time somebody has completed their inpatient and outpatient rehabilitation, they've taken fewer steps with a therapist than the average American takes during the course of the day. And we're not going to treat a problem that may affect 20% of Americans if we continue to battle it in that direction. So we've got to do something different. So one of the other additional things that is a problem right now is that our level of outcome measurement typically is based on things that we can measure in the hospital or clinical environment or research environment. And most of the goals, exactly, it's about 90% of patient goals, are about things they want to be able to do in the home, and about 80 to 90% of the things that we set goals for in rehabilitation are things that we can measure in the clinic or hospital environment. This is some work that Kathy Lang has been doing for a while. She wrote a paper last year that is really quite remarkable. And it's looking at people who have had clinically meaningful changes in capacity measures and what percentage of those people have clinically meaningful changes in participation measures. Stated differently, what percentage of those people who have clinically meaningful outcomes in the clinic or hospital environment also have meaningful outcomes that could be measured in the home environment. And so what she looked at was, the 6-minute walk distance and the 10-meter walk speed, and then looked also at the number of steps per day that they're projected to take at home. And there are a lot of things you could say about the study. It's got a lot of mathematical modeling in it that's a little bit complex to understand. It's a small sample size. There are 48 people. But 100% of those 48 people had improved capacity measures, and 0% of them had improved performance measures. And that is not something that is going to change the needle on what it is that we're trying to prevent, which is further cardiac conditions and further cardiac complications. All right. It's wonderful that they're getting great clinical outcomes, but those outcomes have to be able to be translated into the home environment. And I don't think we're doing a very good job of that at this time. So why is this important? Because we have to be able to increase physical activity. All right. Walking is the #1 way that individuals post-stroke and older Americans like to engage in physical activity. All right. So less than 50% of stroke survivors are community ambulators. 75% of stroke risk are attributable to modifiable risk factors. All right. And of those modifiable risk factors, physical activity is the strongest predictor of a good medical outcome in the first 32 months after stroke. All right. So if we want to be able to prevent, we have to increase physical activity. If we want to increase physical activity, walking is the best way to do it because that's the biggest goal that people have. But more than 50% of the people that we ask to do this are not able to do it. So we have to be able to increase that percentage if we expect to change the community and healthcare problem of recurrent stroke. So one solution is cardiac rehab. And I find it so interesting and appalling that if you've had a heart attack in the United States, you have a 100% chance to be able to engage in cardiac rehab. If you've had a stroke in the United States, you have a 0% chance of engaging in cardiac rehab. It's not funded by CMS, and therefore it's not picked up by most private insurance and third-party payers. Partly because it's hard, all right? So because individuals post-stroke don't have the strength, balance, and mobility to be able to engage in the independent cardiovascular training that is part of phase 2 cardiac rehab, all right? But that doesn't mean they shouldn't get extra therapy that can help get them to the point where they can engage in independent cardiac rehab. And so there's lots of complications in this, and not the least of which is, and I can't explain why only 13% of individuals with heart attacks choose to engage in cardiac rehab. And I don't have any idea what percentage of individuals post-stroke would choose to do it as well. But it needs to be a model that is explored to see, can we increase the percentage of individuals post-stroke who are able to engage in independent exercise, so when they go home, they have an opportunity to reduce the risk of further complications. So cardiac rehab is highly effective. And in the population of individuals who have had heart attack, it reduces cardiovascular mortality, it reduces hospital readmissions, it promotes a higher quality of life. Recently, there's been a lot of work done with heart failure. Those individuals who previously would have been told that they did not qualify for cardiac rehab. And what we have found is that if you still engage them in these activities, focusing on strength, balance, and mobility to progress to the point they can do independent aerobic conditioning, then we can reduce all-cause hospitalizations, heart failure specific admissions, and you can get improvements on the Minnesota Living with Heart Failure questionnaire. And I'm going to present some more specific data about heart failure studies as well. So it's very clear that this is a great model to be able to do the types of things we're talking about, but it has to be modified to meet the needs of a neurologic population. No such programs exist for patients post-stroke, despite similar levels of vascular risk, much worse physical activity. And if we could modify this to meet the mobility limitations of patients post-stroke, we could markedly improve the care and recovery of large, vulnerable, at-risk populations, such as those post-stroke. So what I want to present is kind of the evolution of the field on this over the last 10 to 15 years, primarily with data from work that I've done, that Dr. Duncan has done, Dr. Pasfa, Dr. Ng, and how we have progressed to the idea that this is really where we need to be. So the first study in this was the LEAPS trial. It was the locomotor experience applied post-stroke. Was published in the New England Journal of Medicine in 2011, and at that time it was the largest rehab trial that we'd ever had focus on walking rehabilitation. They had 408 individuals that were randomized into one of three groups, and it was a very, very clever design to get at multiple questions. One group got locomotor training, which is body weight support and treadmill therapist assisted walking training that started at 2 months post stroke. One group got a structured progressive home exercise program that started at 2 months post stroke. And the third group got locomotor training, body weight support, and the treadmill at 6 months post stroke. And until that time, got usual care. And so what that allowed the investigators to do is you had a group that started with early experimental intervention, early home exercise, and then usual care. And you can measure all of them at 6 months post and have that direct comparison also. The home exercise program was a progression of strength, balance, and mobility exercises. Did not include any type of cardiovascular training. And in particular, it did not include any type of interventions that were designed to improve walking speed. And those are not my words. Those are the words of the protocol that was published in 2006 in the first year of this trial to describe what it was that they were going to be doing. But when you look at the data, those individuals that got the home exercise program were about twice as good on every single outcome measure that's presented here than those that they had twice as good of a change in walking speed. They had twice as good of a change in 6-minute walk distance. They had twice as good of a change on the stroke impact scale and the ADL, participation and mobility. And they took more than twice as many, improved more than twice as many steps per day. So it's really a remarkable change compared to usual care. And in one of my more confident moments with Pam Duncan, I said, Pam, what do you think these changes would have been had the home exercise program actually been good? And she got very ruffled and said, what do you mean it wasn't good? It was structured, it was progressive, it was hierarchical. I was like, Pam, for weeks, those individuals got passive range of motion. At no point during a 12-week protocol did they do anything that was cardiovascular or to address the cardiovascular system. And at no point did they take any steps as part of therapy. It's really remarkable that we see this difference in an intervention that didn't have those components. And if you look at the total results, and these are really small lines on this figure. I'm sorry about that. The black lines are the home exercise program. The dotted blue lines are late locomotor training, and the dotted orange lines are early locomotor training. And what you see is that at 12 months post-stroke, there was no difference between these three groups. And that was the big surprise that neither locomotor training group was superior. I've thought about these data a lot and was in this field, part of the group that trained the therapist for the LEAP trial. And what I that we have had a trial that the original hypothesis that walking is better than not. I don't think anybody would have been surprised by that. I think we all would have been spending $13 billion to find out. But what we found out was there were other interventions that were effective. And I'm convinced that the group that got the home exercise program and the groups that got locomotor training got better for the same reasons. That there are different
types of mechanisms that can improve walking capacity. And that's really where the field has gone since 2011 is being able to explore these other elements of training that affect well, again, here Wilson here in this photo, first author of several newspapers. Um, it's definitely here and I will together back in 2010 weeks, so it was interesting. But what Janice and Tara and their group at UBC realized that we need to be able to include these elements of uh, cardiovascular training. Definitely, there's inpatient determining optimal post-directed exercise. That's what the acronym stands for. And so to determine this optimal exercise dose, they had one group that did usual care. Right? So they got less than 10 minutes of cardiac training and about 600 steps per session. Right? Now, 600 steps is still a whole lot better than the 357 that we talked about earlier, 63 for inpatient rehab, but still less than what's recommended. The second group got 30 minutes of aerobic conditioning and had to get it to 2,000 steps. And the third group got an hour of 2,000 steps. And one thing super interesting about these data is that better. Better. Back the guidelines say okay, the 30 minutes of activity is sufficient to be able to get the effect that we're looking for. So both those groups are better than usual care, but the two dose groups were not different from each other in terms of their improvement on the 6-minute walk distance, as well as the um, uh, so again, both those groups are better than usual care, but we're not significantly different from each other. They're carrying these data out to a year, average 6-minute walk was superior. Steps per second um, helps improve outcomes. They carry out to a year rather. What's not presented here is that it did not increase the number of steps per day at home. And so there's no difference between the dose groups and usual care in terms of how many steps they took once they got home. And so really come back to that because that is a problem in this discussion of if we increase capacity measures in the clinic and hospital, what do we need to do to make it with these graduates that you want to run and our goal was to get 2 sessions per week of intensity of training, 2 sessions per week in intensity of cardiovascular training, 2 sessions per week for intensity of walking training. Our strength training was defined as repetition max. It's about 75% of the one rep max. We want to be able to about the 10th or 11th repetition, and then when they could do that stuff. Their sport rate. Person be able to do that. Not the first response we got was from the therapist that we used. Like, what do you mean? You did go through a whole year of training to be able to learn how to do exactly this. What do you mean that you can't do it? And the response was that their facilities were very focused on um, independence and at that point, and that's what and it's better than them. Now it's makes it clear to them. But the point is that you're judged as a clinician and as a facility based on how well individuals uh, functional independence. They say to me, it's a measure that's going to take away from that. But why do you think that if you increase the budget capacity, that you're not going to be able to help them become more independent if that capacity is on the past? So I went to the local facility. I said, you're not sacrificing all of these. I was staggered. I stay calm and how I responded to him. I said, well, first of all, there's no evidence whatsoever that increasing intensive rehab sacrifices quality. Second of all, I would love to know what you're using to measure quality, because I know for a fact your facility you're not. Right? And he got all set there. He said, I've got to leave. I've got to go to the conference. I go off my it went uh, I'll go for a conference. That was run by it's a good idea. Let's do this. So decided to go ahead and run with it. We try to make it easy for therapists. If you are walking intensely and you're measuring their heart rate and then staying in the training zone for at least 20 minutes, that counts as a session for cardiovascular training. So if you do strength training, you will give rest breaks during that session and you're on the training heart rate. Uh, that counts as a cardiovascular session. So it doesn't necessarily have to be big discrete sessions during the course of the week. And if you do take six, you still have another 10 where you can focus on practicing independence. But let's try to make this as simple as we can. All right. So what we found was that individuals seven point seven double just to build how that test but this is one of the things that makes this type of work super hard is that rehab's good for you. Rehab improves physical function and all of these outcomes. And so when you go to a rehab center or you go to therapists that work at rehab, say you need something, they look at these numbers in red and say, stop. People are getting better. My question is, are they getting as much better as they could? So also look at all the small sample sizes, all the complexities that there's like that and stuff like this. We looked at the effect sizes and effect sizes and see the catch out measuring. The effect size was at least like 6 times in between your effect size. So if the intervention and administered correctly, that actually improves what we thought we were doing super well. Now, here's the other part of this. Our therapists didn't do a very good job of getting enough sessions. Right? And if they got 2 sessions per week of each one, what they should be able to get is 6 sessions per week, or the course which we have, they just got about they the group who for 90% without things they get about stuff. So this is not an incredibly intensive event. Over the course of 2 All right. Now, the next question we get, like, okay, get these better outcomes. It's feasible to be able to do frail, so you can't really do this. The population that's frail. And so, Amy passed by, it's been demonstrated that for individuals not qualified for cardiac rehab, because they're in heart failure, still do this exercise intervention, focusing on strength, balance, mobility, be able to get to the point where they can exercise independently. What is the effect of that? They had water sample, 349, great care, great safety, and so awesome. I say these individuals are frail, they were really frail. Right? So 50% qualified as frail, 48% qualified as pretty frail, 2% qualified as not frail. Right? What does that feel like? There. What they see, they found significant changes in the short physical performance battery, includes a balance score, meter air rise score, 6-minute distance, and engagement speed. What's really interesting, look at the smaller subgroup analyses, that what we see that those people that were the most frail actually drove that change more than the pretty frail individual. That the effect sizes and the significance were stronger in the subcategories. And you can see actually some of the pretty frail categories were not statistically different than the frail range from it. All right, so what are the requirements we need to be able to translate? About difficulty of doing this, get people better, get better, and so what we know at this point is that translation to a home environment requires the behavioral modification. Right? It's not sufficient to say this is what we need to do. Individuals who are not exercising their exercise after the stroke, there has to be some kind of behavioral modification. And it's not sufficient just to coach them. Right? So if you do traditional rehab and you send them home and say, we're going to coach you to alter your behavior, doesn't interventions that incorporate real world that they can protect if somebody increases their capacity and you're telephone-based management becomes a very critical and viable to be able to do this. Coaching now covered by CMS bill for it. And if we alter the capacity, and it in telephone or yes, some kind of rehab. If they can disabling offense, broke or otherwise, go home, engage in physical activity. Uh, 25% more likely. So we need to increase the percentage of ambulatory patients post-stroke who progress independent cardiovascular exercise. And we need to increase the percentage who will continue to exercise independently. That's the most important aspect of this. And then we have to determine this trade-off between additional rehab and space. But I know worst thing is going to happen is third-party payers say, you're recommending that we give therapy. Yes, that's exactly what I'm suggesting. I'm suggesting that they get 36 to 40 more sessions in the same way that they would if they had a heart attack. We can't afford that. The medical system can't afford sessions of supervised therapy for individuals post-stroke within 40% of our population. All right. But if they go home and they have a second stroke or they have a heart attack or they have a hospitalization that culminates in some form of vascular death, this is called the that. And how much does therapy cost? And how do we analyze that economically to the cost of rehospitalization, readmission, and re-stroke? How much? What is that trade-off? Because I just had surgery on my ankle. I had really tendon repair. Outpatient surgery. I was in the hospital for less than 4 hours. It was $75,000. And my therapy, that transition, I was paying out of pocket. If I didn't have insurance, my therapy would have been $90 an hour. All right. I paid for a lot of therapy to help me rehab my ankle and not risk re-tearing that before I get to $75,000 to go in and have it repaired second time. All right. So we have to be able to think about services that we provide across the spectrum from supervised physical therapy to independent exercise and what it costs to be able to do that physical thing, not having that problem. And I think that once we all get together, we all put our minds together and bridge this gap between exercise and that's where and that's what I'm looking at. That's my goal of this. Like, you know, it's not better procedure than has been done so far. But thank you very much. I appreciate the opportunity to be here, and I hope you all have a great day.